other topics as well. And I think last time we did the neuromuscular diseases, who a lot of you guys told me to do Parkinson disease. So we're just gonna do like a brief review of Parkinson disease, focusing mainly on diagnosis and management. وإن شاء الله أقدر أفرجيكم أكمل فيديو للتريمر وهيك شغلات. Okay. So let me do the presentation mode. Okay, perfect. As you know, Parkinson's disease is, it's fairly common. It affects millions of people worldwide, and the number of affected patients is actually, expected to double by 2030. And it's estimated that approximately 1% of people older than 60 years in the United States. I'm not sure if there is any data about it in our region. But more of 70% of patients, they report no family history of Parkinson's disease. And we think of Parkinson's disease as a combination of genetic predisposition with the possible environmental factors that give you, this slow neurodegeneration, right? And the hallmark of the disease is that we have degeneration of the dopaminergic neurons in the pars compactica of the substantia nigra. This will cause a dopamine deficiency state. So you will have less and less dopamine in the brain, which causes most of the symptoms, not all of them, because other changes include in the norepinephrine, serotonin, and GABA. So for example, the cognitive functions that comes from with the Parkinson's disease, with advanced Parkinson's disease, is not caused by lack of dopamine. Postural instability is not caused by lack of dopamine, or that's the theory. Repeated falls and perhaps some gait imbalances also, it's less likely to be caused by dopamine. The dopamine mainly, it gives you the tremor, bradykinesia, and it's mainly bradykinesia and rigidity actually. These are the two big things for lack of the dopamine. And this is a nice cross section of the brain. This is a healthy, so here we have the midbrain, and this is the substantia nigra. And you can see that here we have, all of the neurons, they are, well and healthy. And this is the tyrosine kinase stain. And here we have lack of or decrease, loss of, degeneration of the dopaminergic neurons of the substantia nigra. And the same thing on the microscopic level. This is a normal, we have a good number of cells, and here we have less, and here we have less and less in severe cases of Parkinson's disease. And here is we have the other pathological hallmark, which is the alpha-synuclein. And alpha-synuclein, they are these intracytoplasmic inclusion bodies that they are present initially in localized areas of the brain, but then later on they spread. Back in the 80s, there were two scientists. They are called Brack and Brack. I think they are a wife and a husband. And they developed this staging of Parkinson's disease, where we have stage 1 and 2, 3 and 4, and then 5 and 6. And it says that the degeneration and the Lewy bodies and the alpha-synucleinopathies, it starts early on in the brain's olfactory region, and this is usually stage 1 and stage 2. But then it will have a spread from all the way down into the dorsal midbrain. It will ascend a little bit upward. It will go into the substantia nigra and the midbrain and other areas. And then by the later stages of the disease, we will have widespread diffuse involvement of the whole brain. Can you hear me well, guys? Okay. Now, what's the symptoms of Parkinson's disease, right? So we have 4 cardinal symptoms of Parkinson's disease. They have to, these are like essential, right? Which are tremor, rigidity, bradykinesia, and postural instability. Some people, they add gait disorder. بس هم هدولهم الأربعة الأساسيين, right? So tremor, rigidity, bradykinesia, and postural instability. The 2 most important is actually rigidity and bradykinesia, not tremor. Some patients of Parkinson's disease, they don't have tremor, remember. So lack of tremor does not mean that this is not a Parkinson's disease. The most important thing is rigidity and bradykinesia. Secondary symptoms include diminished arm swing, decreased blink rate, which is a form of bradykinesia, faces, which is also a form of bradykinesia, decrease of the voice form or hypophonia, and difficulty turning over in bed, and so on. Let's see if we can do some videos of the tremor. Just give me 1 second. Can you guys see my screen? Let me make this. Okay, here you go. Okay, let's go back a little bit and see some important features of this tremor. Right, I'm gonna try to stop and then tell you a little bit more. Okay, so the main feature of this tremor is what? The patient is resting, right? So here we have a resting tremor. And the other thing is that it involves the arm, it involves the leg. The other thing is that it's an asymmetric tremor, if you noticed. The right side is not shaking. صح? And this is one of the hallmark features of Parkinson's disease. Early on the disease, Parkinson's disease has to be asymmetric. So if the tremor or if the symptoms of Parkinson's disease from the onset of the symptom, they were bilateral, this is very, very unlikely to be Parkinson's disease, and you think of something else, and you think of Parkinson plus, or these other extrapyramidal symptoms, right? And look what happens when she now immediately. So during the action phase, whenever she ترفع ايديها, صح? There's no tremor. The tremor then re-emerges when she is having at the posture. So this is also another form of a posture arresting tremor as well. Now it's actually bilateral. And if you ask the patient, they always have one side is worse than the other. Leg tremor is fairly sensitive for Parkinson's disease. Very few diseases gives you leg tremor this way. Look at her face. She has masked faces, lack of facial expressions, right? And what other things? Okay, let's go back to the presentation. Challenging. Okay, so this is so tremors. It refers to a rhythmic oscillation around the fixed point in the rest or the non-postural position. It's usually the first motor symptom. However, as we said, 10% or 20%, they don't ever have tremor. Some people divide Parkinson into tremor predominant and tremor non-predominant. Typically, it's usually a resting tremor. However, 50% they have the tremor after they outstretch their arms, and it starts asymmetric. It's either a supination, pronation, pill rolling as well. It decreases with action. The Parkinson disease tremor is absent in sleep, so it goes completely, right? And the other thing is that it's a little bit less responsive to levodopa. Sometimes we try anticholinergic if it was a tremor predominant. Okay, so that's tremor. Now, what's rigidity? So rigidity, it refers to stiffness or resistance of a limb when it's flexed passively, activating both agonist and antagonist. It can be either sustained, so like smooth all over, which we call it lead pipe rigidity, or intermittent and ratchety, which we call it the cogwheel rigidity, okay? It's also asymmetric in early Parkinson's disease as well. Bradykinesia is just decrease and slowness of the movements, right? So akinesia is lack of movement, and it can occur either during initiation or continuation of movements, and it affects everything. It affects, the body, the eyes. So in terms of and pursuit of blinking, the face, so mask faces, hypophonia, micrography, so it's all over. So bradykinesia completely. And the patients, they do describe, like I'm just like slower in movement, slower in doing things, and so on. And the rigidity, it's usually the patients, they will complain of maybe pain, maybe stiffness, maybe some, they won't feel like as flexible as they used to be. Postural instability, it's it's balance dysfunction. It's usually also late in the disease. If you have early postural instability, also it's one of the red flags. You should think of something else. Perhaps this is multiple system atrophy rather than idiopathic Parkinson disease. So it's usually 5 years into the course of the disease, right? And it correlates with the disease severity. So and it's a very disabling features. ليش؟ لأنه المرضى they will fall, fractures, loss of independence, and so on. Unfortunately, it's levodopa resistant symptom. So Sinemet will not work for postural instability. The only thing that works is perhaps physical therapy here, because we think of it more of it's more of a brainstem phenomena rather than more of a basal ganglia or substantia nigra. So that's why it doesn't really respond to treatment. Freezing is an episodic inability to generate effective stepping in the absence of any known causes. Have you seen freezing in the clinic? So like, the patient will literally, they will freeze. They can't move at all. It's mainly on turning. So لما بدهم مثلا يلفوا يدخلوا على الباب أو مثلا and they can't do anything and they are stuck for several minutes. And some patients, they are stuck and they can't move. One treatment of freezing is an injection of an apomorphine injection, which is a dopamine agonist, and it can treat the freezing episodes. It's very disabling, the freezing, because people can get stuck really for several hours. Oh, sorry. Any questions, guys? I'm just gonna show you another video. So this one has a resting tremor, and this is a pill rolling tremor. So classic pill rolling tremor here. Again, it's asymmetric. Oh, we lost people. Oh. Can you hear me? Hello? Okay. Can you hear me, guys? Okay, ممتاز. So نشوف another video, fairly same thing. So here we have an asymmetric tremor as well in the hand, and this is a classic pill rolling tremor. And then here we have a tremor upon movement and also upon gait, and we have also decreased arm swing as well. It could be a little bit bilateral, but it's always asymmetric. Okay. Okay, let's go back. So, however, Parkinson's disease has a lot of non-motor symptoms. So it's not only the motor symptoms that we described. We have a lot of non-motor symptoms, and some of them, they start even before the disease happened, and some of them, they start later on. So non-motor symptoms including depression, anxiety, impulse control disorder, psychosis, hallucinations, panic attacks, executive loss, dementia in later part, right? We have orthostatic hypotension, constipation, nausea, vomiting, fecal incontinence, urinary incontinence, sexual dysfunction, olfaction, olfactory dysfunction, dysphagia, sleep as well, for example, REM sleep behavior disorder, periodic limb movement of sleep, pain all over, anosmia, numbness, and paresthesias. We have also pre-motor symptoms. So now we think of Parkinson's disease that it has this preclinical phase, which is most patients, they complain of constipation, anosmia, so lack of smell, rapid eye movement, sleep behavior disorder, which are, you know what they are, which are lack of atonia during REM sleep. In REM sleep, so as you know, sleep, we divide them into, we have stage 1, which is light sleep, stage 2, and then we have the deep sleep or the slow wave of sleep, and then we go into REM sleep. So, and then with REM sleep, you should have complete muscle atonia. However, in REM sleep behavior disorder, we have lack of atonia. So the patients, they will move and they will dream enact. So بيكون بيحلم المريض and they start kicking and fighting each other. You know, it's usually they are fighting someone in the dreams, and you know, you know, so it's fairly common. And then the other thing is depression as well. So these are the 4 symptoms which usually precedes the tremor, the rigidity, and the bradykinesia. So this is a nice graph that tells you that here is we have the prodromal Parkinson disease. So it lasts for several years. Depression, constipation, decreased sense of smell, perhaps anxiety, and REM sleep behavior disorder. And then what happens is we have starting the bradykinesia, the rigidity, and the tremor, they start. At the same time, the non-motor symptoms, they start also to building up as well. Some mild cognitive impairment, fatigue, pain, apathy. And then we will have, you know, in the mid stage, you know, maybe 5 to 10 years into the disease, we will have fluctuations, which we're going to talk about, dyskinesias as well. And we'll have now orthostatic hypotension, urinary symptoms, psychosis. And then later stage, we will have dysphagia, falls, postural instability, and the patients, they will become more and more dementia. And then eventually, you know, death, of course. It's a very sad curve, but or graph, but it's a very, very slow progression as well. So this will take over, you know, 30 or 40 years. So it's a very slow progression. Okay, now the diagnosis. How to diagnose a Parkinson's disease? We have this criteria, which is from, it's called the UK Brain Bank criteria. So in the UK, in UCL, University College London, Queen Square, what they did is that they received the brains, the autopsy of probably thousands of patients with Parkinson's disease, and they examined, you know, exactly what's the pathology, and then they went back and saw what's the clinical symptoms they were, and they found this criteria. So the most important thing is bradykinesia. If you don't have bradykinesia, you don't have Parkinson's disease. That's it. And then at least one of the following: muscle rigidity, resting tremor, and postural instability, right? So you don't have to have all of them. So bradykinesia is asasi, it's the cornerstone. Slowness of initiation of voluntary movements with progressive reduction in speed and amplitude of repetitive action. And how do we examine bradykinesia on neurological exam? It's usually, you know, it starts, so whenever the patient comes into the clinic, how they move, how they interact with you. And the other thing is that we have 3 tests usually for bradykinesia. The first one is this. So you ask them to do big and fast. And then what happens with bradykinesia is that we will have some decrement at the end. So they will start good, but then they will go down. So this is one. The other one is like this, to do it. And then the same thing. They can't open it all the way because they will break down. And the third one is we will have, you will have supination and pronation. So you do it like this. And the same thing, there will be a little bit of breakdown and disruption as well. So this is how you test bradykinesia. That the second thing in muscle rigidity is you move all over. So you move their head and then their arms. You know, you ask them just to relax as much as possible. Resting tremor, you ask them to close their eyes and just relax and maybe count from 20 backwards, and it will happen. And then postural instability is by the pull test. So you stand behind them and then you pull them towards you. Now we have a little bit of exclusion criteria, or they are red flags that this might not be a Parkinson's disease. If you have a history of repeated strokes, so the patient had, multiple strokes and the course was not smooth, progressive. It was more of a, just they have a stroke and then they have worsening of symptoms and then another stroke and worsening of symptoms, which we call it a stepwise progression. This tells you that this is actually, it could be something called vascular Parkinsonism and not idiopathic Parkinsonism. History of encephalitis, back in the day, with the flu vaccine, with the flu pandemic, they had lethargica encephalitica in the 30s, where all of these patients, they became Parkinsonians, right? There's a movie for Robert De Niro who had, it's a very good movie about Parkinson's disease. If you have sustained remission, strictly unilateral features after 3 years, it should progress Parkinson's disease. It doesn't have to, like, it starts asymmetric, but then it progresses into the other side. Supranuclear gaze palsy, early on the disease. So if they can't look up, this is usually a red flag for Parkinson's disease. So you have prominent cerebellar signs. If you have prominent early autonomic involvement, so they are falling down, hypotension, urinary dysfunction early on, early severe dementia, also does not fit with Parkinson's disease. Babinski sign, because it tells you that the pyramidal tract is involved rather than the extrapyramidal tract. And if you have, a tumor on head CT or a brain MRI as well. And the supportive criteria, which is unilateral onset, resting tremor, progressive disorder, persistent asymmetry. So although it becomes bilateral, however, it continues to be asymmetric. Usually they have response to levodopa. So excellent response to levodopa. If you have levodopa response for 5 years or more, and the clinical course for more than 10 years as well. Any questions? Good. So as you can see, the diagnosis is all clinical. So it's all by history and physical examination. The MRI is usually normal, and that scan, which is a SPECT scan, we only do it if we want to differentiate between essential tremor and between Parkinson's disease. It's not very helpful, honestly, most of the time. So it's only by clinical, which is history and physical examination. Any questions? So, just another slide. So the prodromal period, so as we can see, we have decreased smell, maybe some constipation, maybe some rapid eye movement, so REM sleep behavior disorder, and then the patients, they will eventually seek medical attention, which is usually bradykinesia, rigidity, and or tremor. So you ask them, hypophonia, micrographia, so they can't sign, or they, it will be like a small handwriting, right? Decrease arm swing, and also the gait will be abnormal as well, short step length as well. So the symptoms, they will complain of slowness, tremor, gait changes, soft voice, decreased facial expressions, maybe depression or anxiety as well. And you can do, if you want, genetic testing and that scan. This is a little bit, it's only in select cases, not in everyday cases. And evaluation, and then you see for any rapid progression, which is like atypical, or maybe red flags for Parkinson's disease. Early and recurrent falls, it's not with Parkinson's disease. Rapid progression, severe early dysphonia or dysarthria, severe early autonomic failure, cerebellar findings, pyramidal findings. All of these, they go with atypical Parkinsonian disease, and not typical, regular idiopathic Parkinson's. So as we said, the SPECT scan or the DAT scan, which is a dopamine transporter single photon emission CT scan, it has approximately 90% sensitivity and it may be 80 to 100% specificity, but this is only for differentiating Parkinson's disease from essential tremor. However, it does not differentiate Parkinson's disease from, for example, multiple system atrophy or progressive supranuclear palsy or other neurodegeneration, because in all of the other neurodegenerative disorders, the dopamine is also lost, right? So it's not very helpful. In essential tremor, we should have a normal dopamine on the DAT scan, and that's the difference. Any questions? Okay, treatment. You all know this graph from med school for the treatment of Parkinson's disease. And as we said, the cornerstone is that we have lack of dopamine. So we're gonna give the patients dopamine. And we can give dopamine in multiple ways. We can give it either in levodopa, which is L-dopa. So levodopa, it will cross the blood-brain barrier, and then it will be broken down into dopamine by the aromatic decarboxylase. And then the dopamine, it will do its effect. Now, however, this enzyme, AADC, is also present in the periphery, and we don't want that. We want all of the levodopa that we give it is to go into the brain. And the way we do that is we combine the levodopa with a decarboxylase inhibitor. And this is called carbidopa. So that's why the Sinemet is made up of carbidopa, okay? And this will decrease the side effects of the Sinemet or of the carbidopa, levodopa, and it will shunt all of the levodopa that we give it into the brain. Other thing we have, we can give COMT, which they are entacapone. It's mainly tolcapone was taken over the market because of liver failure, which will prevent breaking down the levodopa into one of its metabolites. We can give also monoamine oxidase B inhibitors, which will prevent also the uptake. And then we can give a direct dopamine agonist, which they are pramipixole, repinolol, and apomorphine as well. So let's go into each one of them. So levodopa is the gold standard drug dopamine therapy in Parkinson's disease with the dopa decarboxylase inhibitor, which is a carbidopa, and this will prevent or reduce its peripheral breakdown, and that's why it will decrease the side effects of the medication. Levodopa is very effective for treating bradykinesia and rigidity. It has a little bit variable on tremor. So tremor, usually we treat it with anticholinergic, but sometimes it can work with levodopa. Now, there's this long debate in Parkinson's disease is that whether levodopa will make Parkinson's disease worse. And that's why historically, we don't give young patients with Parkinson's disease less than 7 years. We start them with the Sinemet, which is levodopa, carbidopa, but we give it, but we treat them with other agents. The research has not been very good on this, and probably that's not true. Probably levodopa and carbidopa, they do not make Parkinson worse, and early treatment is fine. It depends on what's the patients they are experiencing. So this is the formulations that we have. We have either an immediate release or we have a controlled release. And they usually come with together, so it's either 25 and 100. So the 25, the first one is the carbidopa, and the 100 is the levodopa. And they come with less, with the 10 and 100. I usually like to use the 25 and 100 because more carbidopa means that less side effects for the patients, okay? And the key for starting Sinemet is to start it super like slow titration. So I usually start half a tablet, and some people actually start quarter a tablet. So either half a tablet, I usually start actually once a day. And then every few days or every week, I increase it into half a tablet until I reach a good dose, okay? And remember, this is all symptomatic, meaning that it should be given during waking only. So there's no point of giving a dose late at night if you don't have any symptoms during sleep or early in the morning. So what I usually do is, like, you wake up the patient, you give them on an empty stomach. That's the other thing. It has to be given on an empty stomach with a full glass of water to increase the absorption of cinnamon, okay? And then uh, and and then after that, it should be an hour away from food. So an hour before and after, because it will decrease the absorption. So we give it at 8, for example, maybe noon or 1, and maybe at 5. And some people, they will require an extra dose late at bedtime if they keep waking up stiff, or if they have a lot of rigidity. We usually do also the extended release or the controlled release at bedtime, because then it will carry over into the morning. And in the morning, some people, they can't even wake up from bed because they are so stiff and so rigid. So if you add a controlled release at the end of, like, just before going to bed, that will help having a smoother sleep and better in the morning as well. So the key is to start very, very slow. So half a tablet or quarter tablet. If you start with a full dose, all of the patients, they will have nausea, they will have vomiting, and they can't tolerate the medicine. So start very, very slow. Any questions on Cinemet? Okay, so we have something called motor fluctuations. So motor fluctuations, which are the on time and off time. And it refers to, so an off time where we have a poor response to levodopa, and then on time where we have improved function. This usually happens later in the disease, not early on. It happens, maybe 5 or 10 years after the disease. And patients, they will tell you that what's my on time is. And it means that, so I take the Cinemet and they say that, okay, it will take me, for example, 20 minutes to kick in, and then it will last for approximately 3 or 4 hours, and then it wears off. And that's what, the off time is. Let's have this nice graph here between the fluctuations. And it's, it fairly happens. Here is the fluctuation in the dopamine level. This is what the off time is, or the off period is here, okay? So initially, it's very, very minimal, because we start the patient and they don't feel it, because they are still within the therapeutic window. As the disease progresses, they start to dip into these off times, right? And more and more. So then we can treat the off time either by changing the medication, so either by making it more frequent. So instead of 3 times a day, maybe we can do it 4 times a day. But also, you want to make sure that each dose is also effective. So we can play with the dosage, or we can play with the frequency of the carbidopa, levodopa, of the Cinemet as well. Now, dopamine agonists, which are another one, they directly stimulate the dopamine receptors, right? So thereby bypassing the degenerating dopaminergic neurons in the brain. They have longer half-life, greater than 6 hours than levodopa. Sleep attacks as well. And they're usually poorly tolerated in the elderly because of these side effects. So they are very good in young patients, younger than 70. They're very good, the dopamine agonist. It's mainly the 2 big ones. They are the pramipixole and the ropinirole. We have a transdermal formulation. I've never used that, actually, rotigotine. And then we have the apomorphine, which is the pen. It's like an EpiPen. It's for freezing and for acute off periods. So this is the pramipixole. So it's usually 0.125 3 times a day, or we have an extended release formulation as well that's given once or twice a day, which is 0.375 as well. And the same thing for the ropinirole as well. We have the COMT inhibitors, which they reduce the breakdown of levodopa to 3,0-methyl-dopa, so thereby increases the plasma half-life of levodopa and its area under the curve. So COMT inhibitors, they should not be used alone. They are an adjunct therapy, right? So they are usually used in conjunction with the Sinemet. And there is a pill that has all three of them: carbidopa, levodopa, and entacapone. So it's mainly entacapone because tolcapone is gone because it has this liver toxicity, right? So it's used mainly in conjunction with levodopa to improve end of dose wearing off, although it might increase dyskinesia. So for example, if a patient keeps complaining of that the Sinemet does not last for 4 hours or it does not last for 5 hours, right? So what you can do is you can add a COMT inhibitor, and this will increase the bioavailability of levodopa. So instead of lasting for 4 hours, maybe it will last for now 6 or 7 hours. So it will have a smoother course throughout the day. Don't use them alone. They do not work. They need to have the levodopa present. Now, B inhibitors, it prevents the levodopa degradation in the brain and limits its reuptake. When they first made them, I think in the 80s or the 90s, they thought that it has, they are a disease modifying and they prevent antioxidation properties. This is not really true. So that's why we use them a lot in young patients in order to, hopefully it will prevent the progression. The data is very poor about that. We have two of them. We have the selegiline and we have resigiline as well. And both of them, they are usually adjunctive medication to levodopa, particularly with motor fluctuations as well. So selegiline is given 5 milligrams twice a day, and then resigiline is given 1 milligram every morning, once a day. And here is the COMT, which are entacapone, 200 milligram with each levodopa dose. That's usually it. We also, we usually try anticholinergic. So particularly in young patients, we have a tremor predominant, so a lot of tremor. You can give them anticholinergic medication. For example, benzotropine or trihexyphenidyl. And amantadine is an NMDA antagonist, and it works for something called dyskinesias. So later on in the disease, when we use Sinemet, patients, they will have dyskinesias. Dyskinesias, they are involuntary movements that are dyskinesias, or like, they just keep like dancing like and uncontrollable. Have you seen Michael J. Fox? It's exactly the same as Michael J. Fox. And they are usually related to, if they are peak dose, meaning that it happens at the peak dose of the levodopa, you will have a lot of dyskinesias. But sometimes they are actually not related to the dosage of the Sinemet. And amantadine can help with these dyskinesias. They can be very disabling dyskinesias. As we mentioned before, the patients, they should be offered dopaminergic treatment when their symptoms. Treatment of early Parkinson's disease, it all depends on the patient, how disabling the symptoms are. If the patient, is okay and they don't want treatment, that's fine not to prescribe them anything. And if they want to do like physical therapy, exercise, until they become disabling. So it has to be directed by how disabling the symptom are, because none of the medications affect the natural progression or the disease course of Parkinson's disease. And again, there's no known benefit of withholding treatment from patients who have disease symptoms. So if they want treatment, if they are disabled, then go for it. Treat the patient. So usually dopamine agonists, as we mentioned, MAO-B inhibitors as well, and anticholinergic, we usually use them more in younger patients. And then, however, the best medication for Parkinson's disease, it's still levodopa, carbidopa, which is, Sinemet. So if If you tried these and they did not work, then just give them levodopa, carbidopa. Just a few words about dyskinesias that we talked about it. We can treat it by either redistribution of the medication, maybe try to decrease the dose and make them more frequent. If it was peak dose dyskinesias, maybe you can switch to an extended release formulation, make it a little bit smoother in the brain and the blood. And also amantadine can work for patients with levodopa-induced dyskinesias. So questions to ask in the clinic for a follow-up of a Parkinson's disease. So how much time does it take for the medication to take effect after each dose? And then how long does it last? And based on these, you can change, it's either the dose or either the frequency. And then do you develop dyskinesias during the mid-dose period, okay? Or the dyskinesias, they are unrelated. If they say that, the dyskinesias and the movements, they happen 2-3 hours after my Sinemet dose, this tells you that this is a peak dose. So it starts, whenever the curve is at the peak. So maybe they need to lower the dose of the Sinemet a little bit or switch it into an extended formulation. Ask them about wearing on and wearing off, of course, and then any early morning dystonia or pain or curling in your limbs, which we can treat that with an extended release of Sinemet at night. And the same thing is that, do you have periods of the day where your medication, they don't seem to work as well? Now, finally, so we have a patient with a Parkinson's disease, so bradykinesia with or without rigidity, and maybe some tremor as well. If you have a tremor and or bradykinesia, you can do levodopa, which we said, dopamine agonist, and the MAO-B inhibitors. The MAO-B inhibitors, they don't work by themselves, so so they have to be as an adjunct. If the patient was young and very much, tremor is a major, like tremor predominant, we can treat them with anticholinergic agents. And then subsequent, we can keep increasing the levodopa, maybe add the COMT inhibitors. Amantadine is mainly for dyskinesias. Later on, we can do enteral suspension infusion and deep brain stimulation, which, it's the surgical therapy for Parkinson's disease. For all of the patients, it's very, very important to have exercise, physical therapy, occupational therapy, and speech therapy. It's very, very important, because it improves gait, it improves postural stability, prevents falls, and all of these, they are actually the disabling and how patients, they die and they end up in the ICU, right? With a broken hip, a broken, shoulder, and so on. So exercise and physical therapy, they are the most important, honestly, in the treatment of Parkinson's disease. Okay, I think that's it for me. Let's see if we have any other videos. And do you guys have any questions? Sam, I can't hear you, wallah.
Does REM sleep?
I'm sorry. Oh, hello. Hello.
دكتور؟
يا هينا كان يبقطع والله هلا بسمع.
الريم سليب behavioral disorders بيزيد الريسك.
Yeah, it's a very good question. بيزيدوا risk factors? Probably they do. And the data is not 100% solid about it. But they are at a risk of developing Parkinson's disease. Yes. So it should be part of the counseling if you diagnose a patient with REM sleep behavior disorder. Similar pathology with the alpha-synuclein and the Lewy body, right? But the relationship is not 100%, but there is some association for sure. Other questions, guys? REM sleep behavior disorder, actually. Any other questions?
دكتور بخصوص drug induced Parkinson عادة بيكون symmetrical وbilateral مظبوط؟
That's correct. It's usually bilateral, and you need to have, you know, it's important with the history is to figure out, you know, it's usually antiemetics, you know, metoclopramide is very common, antipsychotics as well, and then it's usually bilateral, and it does improve when you stop the medicine, but sometimes it can be, you know, later on. And one of the benefits of the DAT scan, you can use a DAT scan to differentiate whether the patient has a drug-induced or a degenerative. This is one of the atypical Parkinsonism, which is multiple system atrophy. So it's also an alpha-synucleinopathy. So, however, it's a very, very diffuse process where it affects multiple systems in the brain. So we have the extrapyramidal, the pyramidal, autonomic. And unfortunately, there's not much treatment for them.
When sunlight strikes raindrops in the air, they act like a prism and form.
So he's reading and he has, you know, hypophonia. So some features of Parkinson's, however, there is other features that it tells you that this is a red flag for an idiopathic Parkinson, including the presence of pyramidal signs, the presence of early autonomic falls. So the patient is already in a wheelchair, if you can see. So they can't walk well, which is very unusual for Parkinson early on. The patient has a jaw opening dystonia here as well. So this is bradykinesia. You see how we have interruptions? It's very, very small. So this is bradykinesia. This is a very good example of bradykinesia. You see how it, you know, بتقطع ايدهم. It's not smooth. So same thing here. Bradykinesia in the feet. Let's see walking. So he's very unsteady here. He has a wide-based gait, if you can see. And this is freezing. So he's stuck. He can't turn. هو قال له إنه to turn, but he's stuck. He can't do it. And this is some shuffling at the end here. That's it. Any other questions, guys? أي مواضيع تانية بتحبوا نحكي عنها next time? We talked about myasthenia, صح? Last time. يا بحكي لرامي يبعث السلايدز لكم guys. لأنه I talked about seizures هاي السنة و multiple sclerosis ولا لا؟ و I think myasthenia وهي Parkinson disease. dementias okay. مش سامعك والله.
Demyelinating diseases.
Okay. So the demyelinating diseases. Okay. We can do it.
شكرا دكتور.
Thank you,
يعطيكم
Doctor.
العافية.
شكرا جزيلا.
شكرا. أهلا بيك.
اسمع والله